What a pleasure to have two world-renowned experts with me today. I'm Shivan Sarna, and I'm your co-host, Dr. Allison Seebecker, world-renowned SIBO specialist, my dear friend, and my co-creator of the SIBO Recovery Roadmap course, her incredible website, SIBOinfo.com, her incredible pro course, SIBO Pro course. See, I love a name that works. And she and I are here together today to talk to you about something that's quite unusual, the potential connection between your sinuses and SIBO. And our very special guest, who I'll introduce you in just a second, is, I think, someone who is going to really broaden your perspective about a lot of things we thought we knew about. So I'm super excited about that. Dr. Seebecker, hello.
Hi, everyone. Welcome.
We've been wanting to do this for a really long time, and I'm so glad that we're able to pull it off. So I'm going to get right to it and introduce everybody to Dr. Skarada. Hello, doctor.
Hello, everybody.
So Dr. Skarada has a very important clinic called the Modern Nose Clinic and Modern Sleep Solution. He is an ear, nose, and throat specialist with the primary focus on the nose and sinuses. And he also happens to be Dr. Seebecker's ear, nose, and throat specialist, as well as her husband's. And I have been hearing about your work, Dr. Skarada, for years, because Dr. Seebecker is like so profoundly changed by it. And we have been wanting to do this for so long. So we're going to get to it. And we are going to show you some images, by the way, a little disclaimer for those of you who are watching, of some surgical procedures. And they're of the nose. I am super squeamish. Like, my husband can have a paper cut and I can want to faint. That's how squeamish I am. And I've seen these images. And for me personally, they're totally fine. I did not find them to be gory. I found them to be fascinating. So I just want to let you know there are some surgical images here. So heads up. And we'll do our best to warn you, and they're not very long either. So before we get to it, Dr. Seebecker, tell us a little bit about your incredible experience with Dr. Skarada.
Yeah, the reason I wanted to thank you, Doug, for coming, Doug, on is because, as you mentioned, both my husband and I went through some procedure with Dr. Skarada. And the situation is that my husband had chronic sinus problems. He had polyps and chronic sinus infections really his whole life, had previous surgeries, still had trouble. I myself developed chronic sinus infections later in life and was really troubled by it. The real connection to me here with SIBO and the GI, but really SIBO, is food intolerances, because as we know, chronic infection of any type, and certainly chronic sinus infections, can cause histamine intolerance. And SIBO also can cause histamine intolerance. But then that limits the foods you can have, because it takes out a lot of fermented food like yogurt or cottage cheese or sour cream, oranges, tomatoes. And one of the biggies is probiotics, like supplements. Many people with histamine intolerance can't tolerate probiotics, which are very important when we're treating SIBO and the GI. So for me, getting this procedure done, it took away my chronic sinus infections, and it allowed me to start eating yogurt again. Of course, lactose-free. Many people with SIBO can't tolerate lactose, but you can buy lactose-free yogurt in many stores or make it yourself. So that's been incredible. It expanded my food tolerances. But I just want to tell you some of the stuff that happened for my husband, because it's incredible. He no longer needs a CPAP anymore. He doesn't even use it anymore. He used it for years. He had all these issues. He doesn't snore anymore. Thank you, Doug. Thank you.
My pleasure.
He told me that he felt like he got a new brain, like his IQ and intelligence went up. His energy went up. His mood got better. He had struggled with depression throughout his life, was on medicine for it, doesn't need the medicine anymore, is off the medicine, okay, for mood and depression. Then the biggest thing that happened to him is he had knee pain. He's in his 60s, had been a runner. We thought he might need knee replacement. He went and got imaging. No, he didn't. What was the problem? Chronic systemic inflammation stemming from his sinus infection. We know this because as soon as he cleared it from this procedure we're going to talk about, it went away. That gave him the biggest impact in his life. He can lift heavy things. He can go up and down stairs without issue. He hardly even knew how much of a problem it was, because you learn to live with it, you know? And one last thing is, he had psoriasis on his legs, on his lower legs, on his calf. That went away. And his shins, gone. His psoriasis is gone. So all of this from clearing his chronic sinus infections. One last thing I want to say is that this is an issue that we care a lot about, Shivan and I, is hidden infection. And we actually had our friend, Dr. Ann Hill, come and give a masterclass on chronic hidden infections, which can be in all different places in the body. She is the doctor who introduced me to Dr. Skarada. So that's how I found out about Dr. Skarada. So, you know, this is really important, taking care of chronic hidden infections, which sinuses can be. So with that, Doug, let me turn it over to you. And Doug's going to give us a presentation first, and then we're going to ask questions.
And Dr. Seebecker, do you want to we'll hide ourselves, everybody, and we'll
start. So if you want to share your screen,
okay,
you go right ahead.
Go for it.
And so in terms of sharing the screen, I have this right there. You're going to see, okay, one more disclosure. Yes, we're doing procedures, and it's kind of like popping pimples, which is strangely satisfying to me. You know, I've got a finger I'm not afraid to use. I'm kidding. But I would say the second thing is I suffer from a really bad case of dad humor. So that might hurt. If
Yeah, I
you're
can attest to this.
This may hurt you, then you've been warned. So there. Now I'm going to share the screen. Let's see.
We welcome anything that makes us smile. So
and while you're getting the share up, yeah. I just want to say that one thing, we'll talk about this more, but I have likened chronic sinus infections to SIBO of the nose, because I feel that it develops in a similar way. We're getting bacterial overgrowth from not being able to clear the bacteria out of the nose. And so take it away.
All right. So, so if you'll take a little walk with me through the woods, I just want to introduce you to a villain that's lurking perhaps in your family or within your group of friends, or perhaps within your nose itself, called silent sinusitis. And the question that occurred to me with my friendship with Allison, as I'm learning more and more about SIBO, is this concept of all the similarities between these two conditions. Some of the greatest advancements in mankind have come when two different, ways of looking at things come together, and then you're able to kind of solve things in a different way. And so, I've taken a moment and I've taken a little bit of time to look at the SIBO literature, all the literature I could find, and I want to share with you this idea of silent sinusitis. So just briefly, silent sinusitis, it's sneaky. That's why you don't know you have it. How do you diagnose it? Well, it's subtle, not so easy. So we want during this presentation for you to know how you can identify whether or not you or one of your patients may have this. And then I'll show you a few case studies to talk about people who have silent sinusitis. It's literally everywhere. And then, of course, we're going to show you some treatment options, which is entertaining. We'll use videos or movies. And then finally, we'll do the Q&A, which should be a good part of it all. So let's move on, and just briefly getting started, I want to talk to you about, I'm going to show you what we can do. What is it that you do in the clinic? Just give me an idea before we go too deep in this talk. Is this something I should watch or not? Well, here's a patient. He is a chef in one of the cities that we have a clinic in. We've got a couple of different clinics. And so he came in not because he had a tumor in his nose, not because he had pain in his cheek, not because he had what you think of as classic symptoms of sinusitis. He just simply couldn't smell. And he's a chef, so that was a problem. So here he is, and listen to his story. Try to get my volume up here a little bit. And it looks like you may not be able to hear it, but I'm going to talk to you about what he's saying. And I might be able to share some of these later so you can hear. They just have no pain at all. This is the left nostril. This is a tumor filling the left nostril. We're looking along the superior surface of it up here, the upper portion. You're looking for where is it coming from? Because, is it possible it could be a cancer? It's possible. In this particular case, it's got a stalk right there. It's a little yellow ball right next to it. And so we divided that, and he's wide awake. He's talking to us right now. And it comes on out, and he said, "Oh, I feel so much better." That's what he'd be saying right now. You can't hear him say it.
Oh my goodness.
Yep. And you see the little finger, the thumbs and the fingers on that structure. So, we sent off for pathology, and he's awake. He's talking. He's like, "Oh, I feel so good." Kind of nice to hear him say
Isn't that outrageous? How did that even fit in there?
Yeah. And so in this part here, so these things grow slowly. This was
whoa. That was huge, doctor.
Yeah. You know, the worst part about that particular situation was the nurse forgot to screw the lid on that specimen container, and it crawled back into his nose. It was so embarrassing. I had to remove it
Oh my
twice.
gosh, the dad
There's
humor.
the dad humor.
Yeah,
There it
that
was.
may or may not be true, but let me just see if I'm able to, with the audio, share the computer audio, headset, microphone, same as system.
Okay, I'm going to let you keep going, but how long do you think it took for that to grow?
You know, I think he probably had that for about a year, and it came on so slowly. It's kind of like you see the let's share. You guys still able to hear me?
Yep.
Yes.
Let's see if you can hear this too. No, you still can't hear it. That's fine. I think I think he probably had that for over a year. So it's hard to know for sure. I see these people a snapshot in time. They
Right.
show up, we look in their nose, and we take care of them. And that's gonna be relevant as we move on with the talk.
Okay.
These things are all little snapshots in time. So if he was talking right now, you'd be shocked, you'd be blown away. And if you go to our website, you can actually see this video. We have a video library on our Modern Nose Clinic website, and you can hear him talk there for real. So you'll take my word for it. But he's like, oh my gosh, that was so easy. And we said, did it hurt? He said, no, it didn't hurt at all. Well, how do you feel right now? It's like, oh my gosh, this is like, here, he sniffed in through his nose, 100% better, he said. And I said, thank you, I owe you $5 for saying that. It was a joke, though. I didn't give him $5, but he still said it. Anyway, so that's an example of some of the stuff we do. So what is this relationship between these two? SIBO, the nose, silent sinusitis. Well, they both have bacterial overgrowth, as I understand things, because of chronic, I don't have it spelled right, chronic inflammation and infection. There's a chronic nature to both. They're persistent, they're difficult to treat. They impact your quality of life in the form of discomfort and ongoing medical attention. They offer, treatment challenges. If you can identify the root cause and fix the infection, the inflammation, you can get the best results. They're difficult to diagnose. At least silent sinusitis is terribly misunderstood. And the symptoms are related to inflammation and infection. So could this be, an equivalent, condition, something to think about? The association, what does the research say about all? And I won't drag this out, but I looked basically at the research. I looked at irritable bowel disease because there's a lot of research on that. I know it's not a perfect match, but it's not terrible. And there's a lot of research looking at medications that, like clinical drug trials, and they found that there's a strong association between sinusitis and the treatment of irritable bowel disease with different drugs. And they blamed it on the drugs. But could they be wrong? Maybe that's not what's going on. Maybe there's something bigger going on. Are there any factors in these GI problems that can predict sinusitis? And, when you think about it, the lining of the sinuses and the lining of the gut is similar. They both have lots of analogous innate immune and epithelial barrier dysfunctions. And so there's perfectly good reason to believe that the two disease entities could be interrelated. They both share an inflammatory component. And then some more questions, instead of more answers, more questions. These are all facts, folks. People who have steroid exposure in the course of their treatment of their disease are 4.5 times more likely to go on to develop sinusitis later. If you have ulcerative colitis, you're more likely to develop it. If you're diagnosed with irritable bowel disease at a younger age, I'm talking 16 years of age or younger, you have a 2.6 times increased risk. If you have a longer duration of irritable bowel disease, you're more likely to go on to develop sinusitis. If you have bowel obstruction, you've got double the risk of sinusitis. These are all like weird and interesting things. You want to know what the answers are, but the answers might be that these two things are far more interrelated than we think. So what is the relationship between the gut and the nasal biome? So kind of get on with it all. So what the heck is silent sinusitis, Skarada? Number one, I don't want to show that just yet. Oh, you're not going to be able to hear me talk, which is a sad thing. I'll probably work on that a little bit more in just a moment, but it's prevalent. About 1 out of 5 people will be walking around with silent sinusitis, and they may have fatigue, headaches, inflammation, postnasal drip, throat clearing, bad breath in the morning, congestion, or is it sinusitis? And people a lot of times think it's just allergies. They're taking over-the-counter medications, and they just ignore it. The cost is substantial. $150 billion a year could be attributed to the underdiagnosis and treatment of silent sinusitis. And why is it so hard to diagnose? It's because sinusitis is so misunderstood. So That other video clip was actually a firefighter and interviewed, and that firefighter basically came in because he couldn't wear his mask because he had congestion. And I was showing a video of his CT scan, and he said, I have zero pain whatsoever in that spot. The left cheek sinus was 100% filled with infection. So that was his story. And the point being is that he probably lived with that for 6 years and had no idea. We went on to fix it, and not just the congestion, but so many other things went away.
Hey,
So
Doug,
what is,
do
yeah,
you have the video available to show that CT, even if we can't hear it? Because I
yeah,
think it's fascinating when you show the infection on the CT. I don't know if it's
yeah,
in,
let's do
if
that.
it's available, but
Yeah, let's do that here. Bang, bang, bang. And there I am. And I'm going to scoot on forward. This is me talking to the patient, and I'm telling a story. That's a CT scan. That's the left cheek sinus there under the eye. Do you see how thin the bone is between his eye and that infection? Wouldn't one suspect that you would have some symptoms there? He had no symptoms whatsoever. As a firefighter, is it possible he could hit his head? Absolutely. And when you ask questions, Allison, like, how long do you think a person may have had it? In this case, you can see, I don't know if you can see my mouse, but a thick bone just adjacent to my finger along the edge of that maxillary sinus is very thick. He's had that for years, maybe 10 years. He's had it for a long time. He even has infection in the right cheek sinus starting up. So,
and so the infection is the gray, right? And over
yep,
on the, when we're
yep,
looking on our left, where we see that sort of darker gray on the left sinus, well, it's
yep,
his right sinus, but in our view, the
yep,
other side of moving your mouse over from not where your finger is.
yep. This is clear.
So
Black
that's
is
clear.
air. Yep, black is good. Air is good. Yep, sorry, interrupt you.
Yeah, good.
So he had other anatomic problems. He had a deviated septum. He has a concha bullosa. And, you know, if you ever wanted just to show 4 or 5 CT scans and to do that, that could be some other thing in the future. Some patients really enjoy knowing how to read the CT scan. So if you were to like Google how do you diagnose sinusitis, this is the boring part where there's major and minor symptoms, but I'm going to look at this in a different way. I'm going to say the way we make a medical diagnosis is you either have 2 major symptoms or 1 minor and 1 major. And I'm going to tell you that those people listening to this, a bunch of you will meet this criteria. Now, nasal obstruction and blockage, well, if you've had it for a very long time, like a colorblind person, you don't know what normal is because you've been living that way for so long. If you sleep at night with your mouth open, that's not normal. Of course, if you have discharge or discolored drainage, yes, we all realize that's infection. Reduced smell and taste, just like that gentleman you saw, that was his only complaint. Facial pain, pressure, and fullness almost never happens. It does happen, but not that often. And usually people say, I don't have facial pain and pressure, so I don't have sinusitis. Well, look at these minor symptoms. Anyone have fatigue? Yeah, that sounds like probably half the people I know. Headaches. Does silent sinusitis cause all headaches? No, they're very complex, but it's a treatable thing that can worsen headaches. So when you have a person with chronic headache disease, it could be that there's something you could be done about it. Cough, postnasal drip, going down the back of the throat, causing sore throat, causing bad breath, causing tonsil stones, causing dental pain. Some people have ear fullness and they're like, I just want my ears to be popped, and they have no idea it's coming from their sinuses. So my point being, it's a lot more common than we think. So acute basically means self-limited. It means it will run its own course. It's usually less than 4 weeks. You think about like viral illnesses, but chronic is more of an indolent thing. And you'll take an antibiotic, maybe you get better, but then it comes back again. So we have 3 villains here. What is sinusitis? The villain number 1, here's this patient you can't hear also, and I'll tell you her story. Villain number 1 is actually inflammation. And inflammation can happen from a variety of different reasons. Yes, infection, we get that. Allergy, environmental things like you're living in a city with lots of pollution floating in the air, that can cause problems. But also medications. What are some examples? ACE inhibitors, antihistamines, nasal sprays. There's a variety of different medications that can cause inflammation in your nose. CPAP, if any of you or your loved ones use CPAP, sometimes you can develop something called rhinitis or inflammation in the nose as a result of that pressure in your nose. It's poorly understood. Systemic diseases like SIBO, well, like other inflammatory conditions, arthritis and these different, rheumatologic diseases do cause inflammation in the nose. The other villain is structural problems. we've all heard of deviated septum, sure. That's a structure that sits in the front of your face. And if you get bumped, like a bumper system of a car, it will crumple to try to protect the driver of the car. So too with the septum. It can happen in utero before you're born. It can happen at the time of birth. The largest part of the baby is their head. The most pronounced part of their head is their nose. It can happen when they're learning to walk, because people learn to walk before they learn to talk. If they have brothers and sisters loving on them a little bit too hard. Some people will never remember when they broke their nose and they think they don't have a deviated septum, but they're more common than you may suspect. Turbinates and polyps, we've all heard of these things. These are structural problems. But the biggest villain of them all is confusion, because people just don't understand what sinusitis is. And so this one here is used for when I talk to doctors, but some of you will be doctors, many of you are patients. It's not so easy to identify it, and there's many misconceptions. For one thing, x-rays are completely and utterly meaningless. A CT scan, yes, but not an x-ray. Number two, will you put a flashlight up to your sinus to try to light it up? It's not meaningful whatsoever. Number three, if you tap on the sinuses and they have no pain, it doesn't mean anything at all. Most people with sinusitis have no pain whatsoever when you tap on their sinuses. So what are you to do if those aren't working? Well, these are all things that a lot of you guys can do also. Try these instead. Number one, history. You don't sleep at night with your mouth open, do you? Do you guys? Anyone out there sleep with your mouth open? Because if you do, you have too much resistance at the level of your nasal airway. Again, while we're doing this, take your finger, plug one nostril, breathe in and out through the other. And I actually like to listen to the patient do it and then do the other side and breathe in and out of that one. And I will find people where it's completely obvious to them and to me, their nasal airway is terrible. And they'll look surprised. They'll say, oh, I thought that was normal. This is normal for me. Well, it's too much obstruction. And then MMT is an acronym for maximum medical therapy. I should disclose to you all that if I have any biases, one bias is I'm a little bit anti-antibiotics, but it's not like I don't believe in antibiotics. It's just that if I saw my daughter when she was 4 walking around the house carrying a hammer, and I asked her, this is a true story. I said, sweetheart, what are you doing with the hammer? She says, oh, I'm looking for things to fix. I said, well, why do you have the hammer? She said, I couldn't find the screwdriver. Do I believe in my daughter? Yes. Do I believe in hammers? Sure. But I don't believe my daughter walking around with a hammer will end well for me. So I think of antibiotics that way. There's nothing evil about them, but we should be a little bit more cautious than we are. Antibiotics, saline irrigation, again, on our website, if you go there, the video library, you can see a video of me irrigating my nose. It's entertaining and it's useful, so you can know how to do it correctly. In the treatment of allergy, there's a lot of over-the-counter options for that. All right, so the diagnostic gold standard is a CT scan of the sinuses. That's how we know for sure if you've got sinusitis. And a couple of points about that is that navigation means that when we do the CT scan and we do a procedure later, we'll use those images. So while I'm doing the procedure, I can see exactly where I am on the CT scan. Enables us to be really delicate and enables us to be very precise so we can make sure we get the problem fixed. Timing matters. You don't want to just get a CT scan without the timing in mind. Are you doing a CT scan on a low symptom day, on a high symptom day, after having done max medical therapy, or before doing it? They all answer different questions, which are all useful. But by the time I see people in clinic, oftentimes we have to repeat it because it wasn't really strategically done. We have CT scanners in all of our clinics, so we go over those results with the patients. So, the other problem a lot of primary care doctors have is, what do I do when I order a CT scan? I get the results, because sometimes the results aren't easy to interpret either. But fear not, we have a hero in our story, and that's the SNOT-25. And that SNOT stands for the Sino-Nasal Outcome Test. It's the most researched quality of life questionnaire in the world of ear, nose, and throat. And it was one of the early quality of life questionnaires. And I want to show it to you because it's really very powerful and it's free. So we use this in our clinic all the time. And I'm going to look over here at the list. When you look at the symptoms, you're going to say, wait a second, some of these symptoms sound like sinusitis, but some of them don't. Need to blow the nose, nasal blockage, sneezing, runny nose. Okay, that's a nasal infection. Cough, postnasal discharge, thick nasal. Yeah, it's that. Ear fullness, dizziness, ear pain. That doesn't sound like a sinusitis at all. And yet these symptoms correlate with sinusitis.
facial pain and pressure, decreased sense of smell and taste, decreased sense of difficulty falling asleep, waking up at night, lack of a good night's sleep, waking up tired, fatigue. That sounds like sleep apnea. Well, these two conditions heavily overlap. The airway begins with the nose. If you can't breathe well through your nose, if you sleep at night with your mouth open and your doctor says, here, go get a sleep test done, you're twice as likely to fail the CPAP. And not only that, you may not even need the CPAP if you can just breathe through your nose. So it does make logical sense to start upstream and fix that problem first. Reduce productivity, reduce concentration, frustrated, restless, irritable, sad, embarrassed, sounds like depression. And then the last three are all, performing either regular or household tasks. Do you have difficulties doing it? Do you have a reduced time doing these things? Do you have limitations? So if you add up these numbers and your score, you can see the little thing on the bottom. If it's above a 20, we can definitely change your life. So this little SNOT 25, they can make it available to you to get later, and I guess they'll let you know how to do that. But it helps us follow people over time. It's free. When our patients come to clinic, as they go through their treatment journeys, we have them complete this multiple times. So we're able to statistically watch them improve, and we don't have to pay for a CT scan over and over again. So that is truly our hero. Okay, so you guys have done a good job here. And we've identified that you do have sinusitis based on your CT scan, your SNOT 25. What do? A root cause analysis. And a root cause analysis, it's important to do more knowing and less guessing. So basically that can involve a CT scan, as we talked about, can also involve allergy test or home sleep test. And once you know what you're up against, then it's easier to put together a treatment path that makes sense for you. What kind of treatment paths are there? There are 4 different treatment paths right here. So this is called our sinus treatment spectrum. You can observe, you can medicate, you can do a procedure, we call it the sinus-off procedure, or you can do a surgery in the operating room. I think many of the people listening to this podcast and the YouTube video will be aware of that concept of observing and medicating. We talked briefly about maximum medical therapy, but the next slide compares, and I'm hoping you can hear this, compares the procedure in clinic with the operating room. So let's see if this one, let's see if I'm going to look over here, even mute. No, okay. So let's see what happens here at this. And I'm going to say that it is not saying anything, so I'll do it. So, if you need to do more than medicate or observe, you might consider either a surgery in the operating room or a procedure in the clinic. The surgery in the operating room, it has to be in the operating room because it is a little bit more painful and you have to be under general anesthesia. Therefore, you'll have narcotics. When you wake up, you may have packing. Sometimes there's packing for the first week in order to make sure when you go home, you don't have too much bleeding. The recovery is approximately 1 week to 10 days, but can range from a few days to 2 weeks. The cost is $3 signs. We'll get back to that in a bit. The success, as defined as, do you need to do this again in the future, is 50%. So 50% of the people are done and 50% of the people will go on to have another procedure. The sinus-off procedure is in the clinic because it's so delicate, you don't need narcotics. We're pretty proud of that. There's no packing because there's less cutting, there's less bleeding. Recoveries in days, not weeks. Typically a Thursday or Friday, return to work on a Monday. The cost is $1 sign. So briefly with that, if you're in the operating room, there's a bill for the surgeon, the surgeon's fee, the anesthesiologist, and to rent the operating room itself. But in the clinic, there's a fee for the surgeon. Thank you very much. But there is no fee for the operating room or to rent the clinic. Those are all complimentary. There is no general anesthesia necessary. It's just a few pills to get you relaxed. The success is 90%. It's not 100%, but it's not 50%. And when we're done during the Q&A part, if you guys want me to explain why that is, I need to do it using my hands and you seeing my face. It's just better than me using words. So these are a few case presentations. These are real patients that had silent sinusitis. Patient number 1 had chronic fatigue, and they also had high blood pressure, diabetes, a family history of cardiac disease at an early age. They thought they had allergies since childhood, and they've been taking over-the-counter medications, Zyrtec, and they had undergone shot therapy previously, but they still would take over-the-counter medications. They got referred into our clinic, and we did our root cause analysis, and guess what? The allergy test, it was normal. So they were pretty darn shocked, I'm not going to lie. We went on to get a CT scan, and they had sinusitis. And they were like, no way, I can't believe that. That's crazy, but it's true. And so they went on and had a sinus-off procedure done. Whoops, had a sinus-off procedure done, and their fatigue got better, their concentration got better. Actually, their snoring got better. And their allergy symptoms improved. That was a chronic fatigue patient. This is a headache patient. The location of the headache makes a difference for those of you suffering from headaches. If it's on the temple, on the sides, by your ears, that's more likely to be like migraines or TMJ, not sinuses. If it's between your eyes, in your brow, under your eyes, behind your eyes, sometimes the very back of your head, called the occiput, that may be from sinus disease. This patient had been using over-the-counter medications for their headaches for years. They had a CT scan. They had frontal sinus disease right where he's pinching his head. It's not a real patient, by the way. It's just a little gift to kind of demonstrate it. This patient did snore also and had fatigue. Once we fixed the sinuses, the snoring, the fatigue improved, the concentration improved, the frequency and severity of the headaches improved. He no longer needed medications. The next patient is the chronic cough, postnasal drip, and this leads in a little bit to SIBO. I'm wondering, of course, we got some experts here who can comment more on this, but really it's a continuum. The infection starts in your sinuses, drips down your throat, all the way down into your lungs, but also into your GI tract. And this particular person had chronic cough. She thought it was related to allergy. She would use an inhaler as needed, and she'd take Zyrtec. The pulmonologist said, this is crazy. Go see the Modern Nose Clinic, see what's going on. Maybe it's sinusitis. She had massive sinusitis. Her CT scan was completely filled, and she really had no symptoms. And she too, we did this, and basically she no longer needed her inhaler. You could say that her asthma was cured, but really there was less infection dribbling down into her lungs, exacerbating her asthma. So she was really, really happy lady. To not have to use the inhaler. Postnasal drip, throat clearing, tonsil stones, bad breath in the morning. This patient was embarrassed by constantly throat clearing, and they wanted to ignore it, but no one else did. The wife was irritated, the kids were irritated, and people at work made fun of them. So the patient saw an ear, nose, and throat doctor, and they were told that they had something called LPR reflux, which we could talk about later if you want. But the patient did everything they were supposed to for that, and yet they didn't get better. So they had a CT scan, and they had a sinus-off, and now they have improved smell, sleep, and the postnasal drip and throat clearing has cleared. Last one is congestion. It starts from the nose to the ears to the chest. This person had ear fullness and saw an ear, nose, and throat doctor, had a hearing test, and was told to buy some hearing aids, sold them some hearing aids. And they told me, they said, well, maybe I had hearing loss also, but that wasn't why I was going. I just wanted to pop my ears. It was so frustrating. So we did a CT scan. They had sphenoid sinusitis, and we treated that. And they said that their ear fullness improved, but it had not completely cleared. And then we did another balloon procedure of their eustachian tubes. It's called the Otosoft procedure. And again, as time permits, we could talk about that, but that's beyond SIBO conversation. So be a hero. If you think sinusitis, you're going to find it. And if you find it, you can get unstuck and you can live your life again. So this one here, I was working on the airport last night, SIBO and silent sinusitis, this gut sinus connection, the impact on your gut flora, the immune system and the inflammation, the impact of taking antibiotic after antibiotic for your sinuses, but having intended consequences on your GI tract, and having shared symptoms, of inflammation, and then headaches. So here's some videos. You guys survived this, and I gotta tell you, I'm gonna try one more time to see if I can get it so you guys can hear audio, headset, microphone array. test speakers and microphones, switch to phone audio, leave computer audio.
We just lost we can't hear you right now. That last thing you did took us, we can't hear you right now.
Connecting to audio.
Yeah, try again, Doug. Can we hear you now? Nope, can't hear you still.
It's working on it.
Yeah.
There you go.
Yeah, there you go. I'm back. Sorry, guys. Bad doctor. All right. So I'm going to tell you what we're looking at. This is a lady who had a sinus surgery before, and she had a massive polyp case, like you saw that polyp before. We treated a month earlier, and she came back to do the balloon part. On the right is the septum. These little white things are tiny square cotton squares, saturated lidocaine. We don't use any needles at all. There's no IVs or anything else. And what you can see here is, I'm telling her story a little bit, which I've just told you right now. And she's just said, I'm fine. Just as easy can be. You can hear it on the website. So it's not painful. But the reason why this is a really good thing to show you, we're about to pull the little sponges out. See all that snot going down the back of her throat? She was oblivious to this. Obviously, she's having, ear stuffiness and throat clearing. And you wonder what this does to your GI tract. She's also having headaches and whatnot. So since you can't hear her talk, and I'm talking to her back and forth, I'm pointing out arrows. That's the frontal sinus up there. I'm going in, I'm suctioning out the infection, sure, but the next video we're going to show you will show us actually opening the sinuses with the balloon. So I'm going to move on to that. And this basically is a series of videos. They're going to show us treating each sinus one after the other, the frontal sinuses first. And you're going to see we're going into the right nostril. And as it goes in, oops, I may have stopped it by accident. As it goes in on your right, towards the middle of this, I'm not sure if this is flipped or not, but the septum, that's going up towards the frontal sinus opening. That little device, the tip of it is 1 millimeter. And that's a little light fiber on it, but we can also see it on the CT scan. That balloon, it inflates from 1 millimeter up to 7 millimeters for 5 seconds. That's all. 5 seconds, it's inflated right there. And we shrink it down and we remove it. So you're going to see there's a little bit of white creamy infection coming out. And what I'm going to do is float that in. That's one hash mark is 1 centimeter. The 2 is 2. And we're floating the balloon up along this guide. And she's right now, she's like, it doesn't hurt. It doesn't hurt at all. And when we inflate it, it's like popping a pimple. You can see right there, it's like popping out. And she's like, oh my gosh, I feel so good. My forehead pressure is gone. Of course, I go up there and suction it out. I mean, I can't leave that stuff there. But you can see how we were able to open there. I inflated again, and we kind of draw it out. And once we suction it away, you can literally look up that little tunnel and see into the frontal sinus and clear any other infection out. So let's go into the next one. Step 2 is the sphenoid sinus. So the frontals in the forehead, the sphenoid is all along the back. And this one's kind of nice because we'll actually be able to see into the sinus. So that little thing there you see that creamy waterfall, that's the middle turbinate I touched. That's a septum. I fixed the septum last procedure, and that to the left is looking into the ethmoid sinus system. I fixed all of that last procedure also. Now I'm going back. You guys can't see the opening of the frontal sinus. I can't see the opening of the frontal sinus, but it's there. And since I have navigation, I can find it. And I just advance the balloon over top of it. And like popping the biggest pimple of your life, and I'm talking ounces of infection here, you got to imagine, what is this doing, stoking your inflammatory process for your body? How could this not impact the GI tract? And there, it's opened. And she'd be like, it didn't hurt. It didn't hurt at all. I'm going inside the sinus. You can see there's infection throughout there. Of course, I suction it out because I'm nice. Let's go to the maxillary sinuses, step 3. In this sinus here, I actually show you what it looks like once I suction it out. So it's curved. So I'm able to bend that balloon device so it fits different angles. Now, there is in the history of medicine, there was a different balloon procedure where you go down the nasal passageway and it breaks the nose from the inside. I don't recommend that at all. That actually shuts down all your sinuses. And It's not something we do at all, and it's very painful, and people will do it over and over again. It's a little bit been it was a good idea at its time, but now things have moved along. So you see what we're doing is we're floating the balloon into this right cheek sinus. We're advancing this little balloon along that thing. We're filling it up like we did before. Bang, see that thing pop? That's about 5 ounces of infection. I mean, not what you're looking at, but the size and the volume of that sinus. Did it hurt you? She said, no, it doesn't hurt. And you'll hear on the website if you go and watch any of the videos. These videos are under the chapter called Super Cool Videos to prove that I've got the mentality of a 7-year-old. But don't miss it. Now, here I'm going there with a suction. I'm suctioning it out. And you can see it's a deep chamber. It goes all the way down to your teeth. And so you can't hear it. It would have been nice if you could have heard it, but you know, you'll take my word for it. It's just not painful. So the last one here is a summary. She was talking about it, but obviously you can't hear her talk about it. So I'm going to skip that one too to give more time for Q&A. That's her talking about it. And this is me fixing a septum, because some people want to see how do you, ear, nose, and throat doctors can't believe you can fix a septum with no scalpels, no stitching, no packing, no cauterizing, no narcotics in the clinic in about 15 minutes. But you can see this is somewhat real time, and I'm fixing a person's septum. Now, again, towards the outside of the screen, that's a deviated septum there, and it's curved into the nasal passageway. You can't see the middle turbinate. I'm going to the other nostril. You can see that thing, the middle turbinate right there. And you should be able to see it on both and see how it's curved the opposite direction. And so it's firm there. When I pushed on it, it's firm. There's cartilage. And so I made a little window here, a little opening, a little trap door. And then we go inside. So to the left is the septum, is a cartilaginous septum. To the right is the skin. There's only 3 parts of the nasal septum. There's skin on one side, there's skin on the other, and there's structure down the middle. The skin is where all the blood vessels, the nerves are, all the good stuff. We don't mess with it. We don't mess with it at all. We just push it out of the way. But the cartilage, the structure down the middle, has no nerves and no blood vessels. And that's why we can do what we do. And it doesn't hurt. We do this on 12 and 13-year-olds, and we do this on adults too. And they all do fine. So here I'm going to go in there and I'm going to take out, like, it's almost like clipping a toenail. See right there? It's like a toenail. And we remove it like that. And you can see how now suddenly there's skin on the left side and the right side, but the structure in the middle is gone. We preserve the structural component of that, but we remove the crooked part. So after the procedure, you're just as strong as you were before. You don't lose any strength. It doesn't change you cosmetically. There's no black and blue marks or anything like that. There's no swelling on the outside of your nose. And I did this for Allison and her husband. I hope you don't mind me sharing that, Allison. So we're going in.
Not at all. It was amazing. And I watched this exact thing being done on my husband. It was amazing. And I'm thrilled.
Yeah. You know,
and I can attest, there's no pain. It's amazing.
Okay. Thank you. That's good. You can vouch for it, but the patients say it too. And it's kind of neat hearing them talk about it while you're doing it. And I asked him right at this point, I said, do you have any advice for someone the night before their procedure if they're watching this and they want to know? And he says, it's a work in progress. I said, okay, it's fine. And then the end, I asked him again, can you comment now? Right here, he says, oh my gosh, it was so easy. I'm breathing really well. And he was done. I don't know, was that 5 minutes? It was something not long. So, you have to be able to fix the septum when you're doing this. It's not just the balloon. So the sinusitis dance, simply put, you've got one of these symptoms you never thought was sinusitis: ear congestion, ear fullness, postnasal drip, sore throat, tonsil stones, chronic cough, asthma, breathing, SIBO, allergy, viral illnesses, chronic tonsillitis, headaches, or classic sinusitis symptoms. What do? You go into your provider, and when your provider says, hey, let's just watch it. That's not terrible. Let's try over-the-counter medications. That sounds fine. I'll do some saline. Okay. Well, maybe you need an antibiotic. Fine. You get better. Then you get worse. And I call that the sinusitis dance. You bounce back and forth. Or you could get a root cause analysis at the Modern Nose Clinic, and you could have the full treatment spectrum presented to you. And everyone picks something different, and that's fine. But you deserve to have choice, and you fix the root cause of the problem and you break the cycle. So this is the Q&A part. And I just want to apologize for talking straight for so long. I'm going to stop sharing my screen.
Don't apologize. That was fantastic. Thank you.
That was fantastic.
Thank you.
That was fantastic.
Okay, can I just take it away with questions?
Yes, do it.
Okay, so we just saw these videos of the procedures that you're doing. Can you like list out what are all the things that you may do when you go in to someone's nose?
That is a really good question. You're the first person to ask me that question. It's a challenge that we have, and it's a problem that our whole field suffers from, is it's not one thing. It's a series or a collection of different things we do. If you can imagine the sinuses here, the frontal sinuses here, maxillary sinuses here, ethmoid between your eyes, and there's a front set and a back set, and the sphenoid all the way in the back. So it could be any combination thereof. There's a septum down the middle that could be crooked. And even with the septum being crooked, sometimes the posterior deviation, it's a superior deviation. So different parts, or sometimes a septal spur. There's turbinates that dangle down into the nasal airway like branches. They should not be removed. Most ear, nose, and throat doctors will remove them, but made them nice and skinny. You saw some skinny middle turbinates on those videos. They were beautiful. I wish my turbinates looked like that. Mine don't. And then there are things like polyps or any lesions. Is there a fungus ball? Fungal sinusitis needs to be mechanically removed. Osteomas and cancers and whatnot. So we call it the Sinusoft procedure because in the beginning we called it a balloon procedure, and some people felt it was being misrepresented because they thought it was just a balloon. And really, the balloon part's 5 seconds of it all. So there's so much more than that. So we call this collection the Sinusoft. And as you go through our clinic, if you were to decide to do that, you would know exactly what steps we're doing, and you can even watch videos to see each of those steps if you wanted to. I don't know if that answers the question.
Yes, it does. Yeah, because when you do a CT, you'll see what's there in that person. So basically, like the way I understand it is what you're trying to do is, and correct me if I get this wrong or add to it, is like restore normal anatomy as best as you can, fix whatever is there that's amiss, and bring back proper drainage and airflow. That's the way I think of it. Is that right?
Yeah, can you imagine? We breathe, take a breath in and a breath out over and over again our whole life, and we often don't even think about it. But yet, when you can breathe clearly, I mean, these patients afterwards, they have no idea that they have decreased sense of smell and taste. And I'm promising you, if your septum's deviated, you're not using one side of your nose to smell and taste. And then once they're able to, they will text me, they'll call me, they'll follow up stories. I was camping and it was this starry sky, and I took a deep breath in. I couldn't believe I could smell the forest. And I just was like, I could smell the outdoors. And I've never been able to do that before. Or like, I didn't know you could smell orange juice. I didn't know. I just thought you tasted it.
Check it out. So
Yeah.
my husband David, he never ate oranges, and there's a whole bunch of stuff he never ate. And after this procedure, he started saying, "Oh my God, this tastes so good." It started having him eat all this greater variety of foods because now they tasted good, and oranges was one of them.
Yeah.
Siobhan, were you going to say something? It looked like
I
you were
have
gonna...
so many questions. You keep going, Allison, because you have a slight time limitation, and I can talk to the doctor when you're gone. Go ahead.
I don't have that much of a time, but we'll just see her. Okay, so you asked us to remind you to explain with your hands why the Sinusoft procedure that you do is 90% success, not 100.
Yeah, if any of you guys want to know how to conquer the world, you surround yourself with really intelligent women and they will keep you straight. Thank you for that. I appreciate it. That's been my strategy. So far, it's been working all right. So these are your frontal sinuses. And if you will, they drain down this way here. And so if they're not breathing, if they're not ventilating well, and we're going to do a sinus surgery on this side, and on this side, we'll do a Sinusoft procedure. For the sinus surgery, what we would do is we'd take a drill or cutting instruments and we'd cut that open, not because we're mean, but because that's all we've known to do for 70 years in ear, nose, and throat. We had no idea that there was a better way to do it. And we're not trying to cut the skin. We have to cut through the skin to get to the bone. We're trying to cut the bone. We're trying to make it so that that drainage outflow tract is more open, and we want to get up there to clear infection out. On the other side, we're going to be doing a Sinusoft procedure. We're going to float a little tiny balloon there. It's 1 millimeter at the tip. We inflate it for 5 seconds. We shrink it down, we remove it, and it will squeeze it open. And it turns out it stays open forever because the inside of your nose functions quite a bit like a Coca-Cola can. If you take your finger in the side and you push in the side of a Coca-Cola can for 5 seconds, you remove it, there's a dent, it stays that way forever. And I'm telling you, we are as surprised as you are to hear this. But it turns out the bone in your nose is about the caliber of the bone in the Coca-Cola cans. And so you push it out, it just moves it. I mean, I guess they're microfractures, but obviously this has been around for like 12, 14 years. And there's been more research on doing a balloon to treat sinuses than on doing surgery to treat sinuses, because it's been comparing the two. It's a ton of research on it, and it's safe. So that's that. Because you have cut skin on the surgical side, you have exposed bone in a circle, the body naturally wants to heal like this. So much of what we do after sinus surgery is going into your nose in clinic and cutting it out again and again. And yeah, it doesn't feel good. And the packing and stuff to try to hold it open. And so 50% of the time it's going to heal down like this. And what we do is certain sinuses, like the cheek sinus, we'll make the opening gigantic. We'll say, I'd like to see the body heal that over, is probably what we think, or we might say it out loud, but it's not a good idea to do that. The nose is not designed to have a giant hole in it. It's supposed to be the way it's supposed to be. You should do less cutting. So we just stretch the natural opening so the air, when you blow your nose, it captures the air and it funnels it through your sinuses. I was washing my car the other day, Allison, and I had a hose, and unfortunately, I didn't have the little, what do you call this, the squirt gun thing on the end. And I want to squirt my 10-year-old daughter because I'm a dad. And so I had to take my finger over the opening and kind of pinch it off until it shot out. That's physics. That's how the nose works. So you need to have a tight opening, but it needs to breathe. So when you blow your nose, it'll shoot the air through your sinus like a jet of air. And if it's closed off completely, it needs to be open. But if it's open too big, you'll never be able to generate those forces.
Well, that's fascinating. Okay, so you just explained why sinus surgery has the 50% rate. Did I misunderstand? Were you also going to explain why the sinus soft procedure is 90, not 100?
I have to tell you, I'm a numbers geek, and we measure a lot of things. And so in the beginning, I actually went to a rhinology meeting with a bunch of geeky ENT doctors, and I had measured, this is before the sinus soft thing. And I told they're all my friends, right? And I said, hey, I just measured all my patients. 50% of people said, knowing what they know now, they would do it again. That means 50% said no, and everyone gasped. I said, why? You're probably 48%. You probably suck. And so I said, go back and measure your numbers and report back. And guess what they told us the next year? Guess what their numbers were? Shivan, what do you think? What do you think their numbers were?
So this is for clinical surgical classic surgery?
Yeah, classic surgery. What were their numbers? Mine was 50%. What were theirs?
And this is people who would do it again. 0.
These are other ENT doctors who did sinus surgeries, asking their patients, what's my success rate? And that's how you pick success rate.
Yeah. I don't know, like 90%?
They didn't.
Oh, success rate, 0%.
Well, those doctors didn't go back and measure it, even though I challenged them to do it. 0 people. I mean, there's like 1,000 of us. 0. Because who wants to measure the results when they suck so bad? And sinus surgery is just like that. And at the time, we didn't know anything else. I had no reason other than I thought what would happen is there'd be a person with a 70% success rate, and I had a 50%. I could find out what they're doing differently, and we could learn together to get it better. But no one measured it. And so I measure things. In the beginning, when we did our initial sinus off stuff, our success rate was like 60%. And we kept making little changes. And actually, one of the biggest changes happened. We were around 80% for a long time. And we were hitting our head in the ceiling. Then COVID happened. And they said, we can't have anyone come in the room to observe. And so, because it was COVID, they had all the mask things. You probably never heard of it. Something called COVID. We had to wear masks anyhow. So, and then it hurts my feelings a little bit. This is the case, but my success rate went up to 90%. It went from 80 to 90%. I was like, oh, I must be getting distracted. I didn't think so. I thought I could talk to someone and work, but then I started saying, I want the highest. So who's failing? Well, there's probably 3 different groups of people with resistant infections because they've been doing too many antibiotics, people with biofilms, which is something that I know you're interested in too. And biofilms are super interesting. And then people may have an immunologic disorder. There's more immunodeficiency out there than is diagnosed, and some of them are fluctuating, so it's difficult to diagnose it. So, I mean, rather than go on and on, I'll let you guys ask any extra questions.
Do you want to elaborate on biofilms now, Shivan? Did you have any particular questions?
Well, is snot just in general a biofilm?
Oh, that's a good question too. So in general, what is snot? Snot is basically not just bacteria. But your body, like if you said to me, hey Doug, guess what? What, Shivan? My nose is a snot factory. I'd say, yes, it is, Shivan. Yes, isn't that wonderful? That's a snot factory. So on one hand, there's little glands that are pumping out a layer of secretions, and the secretions have 2 layers on it. The top layer is sticky, and the bottom layer is watery. And then there's little fingers that beat along the sinuses and they're cilia, and they'll push that carpet of secretions along a predetermined pathway. It's not smart. It's always going the same way. And so these tiny little streams form rivers, and they join up and they go all the way down the back of your throat, like you saw that one patient, into your stomach, where presumably your stomach acid will kill it. And then there's that constant water flow. And so if you have something breaking that system up, then things like COVID can get through, can penetrate through. And like one big thing is not drinking enough water. If you don't drink enough water, then that ratio of stickiness to wateriness should be 10% sticky, 90% watery. It's just a kind of it'd be 50-50. It starts getting clumpier. You might be clearing your throat a lot because it's all clumpy. So the bacteria gets into it. And it could be a small percentage of bacteria or a high percentage. It could be really virulent bacteria or very potent bacteria or very mild bacteria. It could be a virus, it could be a fungus. But as that river is going down the back of your throat, it's all snot. And it could be, infected. It's a polluted stuff spilling down onto your tonsils and down into your stomach. So that's the snot part. And then the biofilms part, I'm going to do this the way I explain it to patients, and you guys can either tell me that you think this is not a good way to explain it or challenge me or whatever else. But I tell them the way one strategy the bacteria will use to try to overcome being repelled from your body is it holds on to its little buddy's hands really tight. And so it essentially becomes a heavier and bigger structure. It's more difficult for the cilia to push it out because it's so big. And so if you take an antibiotic as an example, the antibiotic is not smart either. It doesn't spill into your sinus cavity. It goes into your bloodstream, and it goes everywhere the bloodstream goes. You take an antibiotic for a UTI, it's going to impact your sinuses. And so the interface where the bacteria is holding onto the wall with its little feet and little fingers will start to melt away like a stick of butter on a skillet. And as it loosens its hold, now the body is going to try to push it up. Now, if you put the skillet on, you have a big stick of butter for 20 seconds, you turn it off, it gets a little loosey-goosey, but still there. If you put it on there for an hour, the whole stick of butter will melt. It's all watery. So it might be that if you do an antibiotic course long enough, you could shrink it down enough that you can get out even a tight sinus opening. Be better if the sinus opening could breathe. So that's a long answer for biofilms. Biofilms, I think, sometimes we'll go in there with a little squirt gun with squirt suction to mechanically wash out either the biofilm or the resistant infection, because it overcomes those 2 defenses for the nose.
Do you ever use biofilm disruptors?
I think they're awesome, and we have a ton of research looking at these various things, like when you put antibiotics and you irrigate the nose. A lot of these things are promising things that don't work as well as we thought they would. There are some that do work well, though, so it's not like don't do it. I mean, we love nasal irrigation because it's inexpensive, it's very safe, it's natural, and adding to it, like for instance, adding mupirocin, to me, I don't think that there's much harm in doing that because it's not terribly expensive. But
this is one of my favorite hacks that you have, and I'm so glad you're talking about it. So for anyone who doesn't know, mupirocin is an ointment that is a prescription, correct?
Yes.
Yeah.
Yes.
But it's inexpensive.
Yeah, and mupirocin is one of the few antibiotics we have that can even kill MRSA. So it's still, I mean, when the inevitable zombie infestation hits and you have to run for your life, you should probably grab your tube of mupirocin because it'll probably even stop zombie bites. I'm just saying.
Right.
Don't hold me to it.
Can you explain how you use the mupirocin in the lavage?
One way to do it, and I actually love these ideas, just so you know that. I love these ideas. Just because the research isn't showing that they work as well as they could, I think the reason it doesn't work is because the sinuses aren't opened, like including ozone. I think ozone would work better if it could get through the sinuses. And the idea that the ozone somehow has a brain and smart and it knows to move through this wall to get in here and kill it is probably not the complete story. It'd probably be better if it just naturally flowed in and out of there. So you can kind of, you know, if you're trying to get your fleas out of your house and you have to shoot these little bombs or whatever, and they have to float around, you want to make sure they float around the rooms as best you can. So I'm just saying, but I don't know. I'm not an expert with ozone. I'm just saying. But I would say the mupirocin, all these other things, if the irrigation. So how do you do the mupirocin? I'd say do about a 1-inch length into a rinse bottle. And I'm really cautious about having people microwave the rinse bottle with water in it, because you're going to have plastic, you're going to have microplastics or whatnot dissolving from these disposable bottles. So if you want to heat your water in some other way and put about, you know, an inch length in there and kind of mix it up so it dissolves, then when you're irrigating your nose, you're actually delivering mupirocin also throughout the nasal passageway. Could you do other ointments? Yes, you could. Are these things off-label? It's not FDA approved. It's true. We haven't done the research on it. Some of these things we've done research on. So all of those things where you go to the compounding pharmacy and they order different things to send to you, those compounding pharmacies make a lot of money. The patients have to pay a lot of money. And we did it because we were so excited. It solved so many problems. We don't want an antibiotic to get your GI tract, but we want to get this. The results don't work unless your sinuses are breathing. So these are some things, you know.
You know, one thing I wanted to say about this is a great place to mention it is the way you teach to do nasal lavage with, you know, like you use the Neomed bottles is what we're talking about here, the squeeze bottles. That was new to me that I'd never thought to do. And it's the simplest thing is to use 2 and use 1 bottle for each side. And I just want to share that that was a game changer for me. I just never thought to do that. I used a half a bottle in each side. And when I started doing it the way you said, 1 bottle in each side, wow, what it did. Like just for people doing that on a regular basis.
Like back and forth, Allison? Or
no, just like you take 1 bottle and put it all in the whole, 1 bottle all in the one side. You're done with that. Now you grab your other bottle and put that whole bottle in the other side. I mean, you don't have to buy 2 bottles. You could refill the same bottle and then now just do the other side. But it's nice and easy if you have just 2 bottles. But just the concept of not doing 4 ounces in each side, but 8 ounces.
Yeah. I was briefly in academics, and there's all these things when you're teaching medical students that they love little sayings that you could remember, and they made things. So the secret to pollution is dilution is one of the ones that you would say. And the point being is that if you've got a certain virus in your nose, and they have different virulence, so you may have a given virus may need to have 100,000 virus particles before you become symptomatic. You're carrying the virus, you're 90,000, you're not symptomatic. Okay, that's cool. You can go to work. You have no idea. So if you have 200,000, 500,000, and you irrigate your nose, you dilute it down. And so if you dilute it down enough, you know, then your body can kind of overcome whatever is left. I mean, the nose is supposed to be cozy. It shouldn't be a giant opening, a giant hole, you know. So I'm going to just let you guys ask questions instead of going off on tangents.
Okay, I got so many questions. All right, Allison, did you have any more that you wanted to hit?
Of course, but you go ahead. We'll go back and forth.
Okay. What do you think about this product? Do you know what that is?
I see nasal clear. Can you tell me what the ingredients are?
It's right, physician standard nasal clear. Oh my. Yes, of course. You know what? I'm gonna go look it up, and then I'm gonna.
Okay, then let me ask you something that directly relates to what we were just talking about. Here's another thing I think people worry about, particularly in the more alternative medicine world. We're taught that we have certain good bacteria, probiotics in our nose. There's certain keystone species. So I think a lot of people get worried. Could you do too many nasal, like of saline, too many, and wash away what's good? What can you overdo it?
You know, it's such another awesome question. You know, in case you guys are unaware, you're probably aware that you can take stool from a healthy person, put it in an unhealthy person, and it helps. Guess what else you can put into someone? You get snot from a healthy person, put it in an unhealthy person, and it helps. So these concepts are so parallel. There's stuff here, and ear, nose, and throat doctors aren't talking about this. They're not thinking about this. I think they're barely keeping their head above water, frankly. And so, you know, there's something to this whole thing. It's interesting. I looked at the research. So I would say that you know, I think you can do anything too much, but it's kind of like wash your hands or brush your teeth. If you think about it, you know, there's probably you brush your teeth once or twice, And then, oh, there you go. There's a supplement. And then and that's okay. If you do it too many times, it could be too much. But when you're diluting things down, okay, let's look at this here. I want to say,
Biofilm and the snot's constantly rebuilding. Okay, what do you got
So
here?
yeah, so you're saying lavage, maybe 2-3 times a day would
Yeah.
be the max.
I would say an entire bottle on the right, an entire bottle on the left in the morning, an entire bottle on the right, entire bottle on the left in the evening will be pretty good if you're feeling sick, you're going on vacation, you think you're coming down with something. If you want to do it 3 times a day, that'd be fine. And when you
Great.
go beyond 3 times a day, you probably get limiting return on the benefit from that. So
Awesome.
so the other thing, Allison, to finish it off, another thing you're doing is, even if you can't clear it from the sinuses because it's too tight, as the infection is spilling into the nasal passageway, when you do that, you clear it out so it doesn't dribble down into your lungs, into your throat, into your tonsils. So there's some advantage to that. You're sharing me that label. Now
Okay,
it's not here, but in general,
yeah.
I would say about labels in general, it's awesome looking at that. All these over-the-counter nasal sprays, a lot of them have either oxymetazoline or Afrin in it, and that is a no-no.
This is herbal.
Yep.
This is hardcore naturopathic herbal. Do you see it?
Yep. I'm going down the list. I'm reading it all. Got it. Silver, water. Yeah.
Shivan, is this something you've been using? Are you into this or something?
I do like this. I do like this. Yeah.
And
So
what I would say about this is, this reminds me of, I went to visit my sister and my mom and thing over the weekend, and I used my nephew's shower and I see all of his bathing products and stuff there.
Yeah.
And you're like, for your hair and for your beard and for whatever else. And I'm convinced that these things are all helpful. And some people find things to be helpful more here or there. And so there's nothing bad there. It's all good stuff. And so then I would be more towards like this, well, it's my nephew wasn't there, but if I was worried about the cost, if it's $50 for the shampoo versus $5 a shampoo, and for some people $50 isn't a big deal, and other people it is. So I would say there's nothing bad about that, and it could be helpful. All these oils and stuff, it's kind of like putting conditioner on your hair and whatnot, but the rinse bottle is cheap. So if you're gonna only spend your dollar once, you might start with the rinse bottle.
Okay, and then what about xylitol?
Yeah.
I think xylitol is great. These things break up biofilms, and I think if you could penetrate the sinuses once they're open, it'll work better. But there's nothing wrong with doing these things at first, and if they work, you're great and you're done. That's fantastic. We call that maximum medical therapy. So try all those things first.
Okay, and when you all were talking about putting the bupersin in the 2 bottles, the lavage, well, help me again. Are you heating it?
Yeah, well, you want to melt, and you look.
So
You're
you want to melt not the bottle, but you want to melt the
You put it in warm water.
Warm water.
Yeah.
Okay.
Yeah.
Okay.
And I do microwave mine. I'm sorry. It's just if I'm not going to microwave
Allison,
it.
you are a rebel.
The thing is, I think it's more important to do it than not. And honestly, I'm not going to go through the thing of putting it on like the stove or something. I'm just not going to do it. So I'm just going to be real.
Yeah, right.
Let's talk about being real. This is something that I think we should talk about, because I don't do this very often. And this is not me wearing my legal hat. I'm just going to tell you the facts. You guys have to choose your own decision. So microwave is one, but another thing is using distilled water. How important is that? And
now, I have to say, I do use that. I buy it.
I hear you. And here's the relative reasons to do things or not do things. I first thought, well, can't you just boil the water? I mean, that's going to kill things. And there you go. And then we had a toxic algae bloom. And I was like, oh, if you were to boil the toxic algae bloom, you have the toxins still there. So it is not perfectly. And there are some things that are brain-eating amoebas. It's a real thing. It's not, but it's so infrequent. But if it happens, it captures attention. And so from a legal standpoint, you're never going to find an ear, nose, and throat doctor or a company saying it's okay to use use water from your sink. But like what you were saying, and I'm not advocating this, I'm saying I use it from the sink because I'd rather use it from the sink than not do it at all. And getting the distilled water can sometimes be a hassle. But I mean, if you use distilled water, it's better. We actually have a distiller in all of our clinics. We're constantly distilling water. So there you have it. We don't distill anything else, just
But
water.
I appreciate that. I appreciate that being real. Like there are times where I'm on vacation or something and I don't have distilled water, and I think I'd rather do it, and I'll use tap water, I'll use sink water, than not do it, And
one thing is never, ever, ever clean your contacts with tap water. Just because we're on tap water. Just okay. Just a side note there. Okay. How easy is it to get a deviated septum?
I think that many people's septum could be deviated, and it doesn't matter. It doesn't matter unless one of two or three things. One is you don't sleep at night with your mouth open. Do you? Yeah. Number two, block one. Here, I'll do it right now. You go. Another side. And literally, when I'm listening to people, sometimes I can hear the gurgling, I can hear the congestion, I can hear the one side's worse than the other. And so I find that from a physical exam standpoint, like as a provider, that is probably more meaningful than looking at the nose. Otherwise, you're looking at this anatomy, you're like, I don't even know what I'm looking at. You're only in the front 5%. Ultimately, see, I would say ultimately it's not 25. And if a person thinks they have it and it's above such and such, well, then it's worth it to look in more and more. But deviated septums are common.
They're common. Okay.
Yeah, like we're not many. I mean, I guess some people can be born with them. You explained that about being,
in utero.
But so many people get them from like playground accidents and things. Yeah.
Okay. So I have so many questions. It's very important we keep going because I'm building up to this one thing. Okay. Would love to include talking about culture and DNA swabs.
Yep.
Okay.
I love it. So we started this clinic with this like a database approach, and really this has been a bit of a pet project for me. I don't want to go on a tangent, but we'll measure all these things. There's 3 measurements of success. How quickly does a person get better? So we want to be efficient. How affordably do they get better? I mean, if you spend all the money in the world, you can get better really, really fast, but you have to be mindful of how much it costs, and how completely do they get better. And the reason I tell you that part is because in the beginning, I cultured everyone all the time, Shivan. And I learned a bunch of stuff, but we found that it did not change the outcome, and it was an extra expense. So if I'm culturing a person, which I'm going to get to your second question right here, that means I take some of the bacteria or the fungus or whatever else, and we put a little tiny test tube, and think about what we do. Okay, this is important for you guys to hear this because it makes sense when you hear it. A nurse will call up the hospital, whatever, please pick up a specimen. And they message this out to a person who drives a little minivan. The minivan's driving all around our town. And the weather could be negative 20 degrees. It could be 110 degrees, whatever. And we got our specimen done in this little tube with a little bit of liquid in it. It's sitting in a Ziploc bag in a receptacle outside, waiting for them to pick it up. Oh, and I called your nose, Shivan, on Friday evening. And guess what? They had already come by, so they didn't pick it up until Monday. And I want to believe that they pick it up on Friday, go straight back to the lab, and they culture it out in a culture dish. But they probably don't. They put it in a culture dish eventually. They put it into an incubator, and then they try to grow it. And I have to tell you, I am so confused why fungus will grow in your nose so easily, but you can't get it to grow on a petri dish for the life of you. You know, it's craziness. That's why the other thing you asked is so interesting. So to finish the first one off, it was an extra $400 or $500 to do cultures or whatever it is. It's expensive. It's a lot of labor. It took forever to get an answer back. It was imperfect. I think it missed a lot of things. I think a lot of naturopaths will be like, my clinical judgment says there's something going on, and it comes back negative, and they're like, well, I guess I was wrong. No, you could be right. The technique was wrong. And now there's another thing for swabbing it to look at like the biometrics. You want to look at the genetic footprint. It's kind of like Star Trek, where they have their little thing and they look through the sand to find out if there's genetic footprints. And I'm going to tell you right now, it works and it doesn't work. So if you ever culture your patient's noses and it doesn't grow anything out, that doesn't mean you're not right. It doesn't mean you're not right. I'm a little bit disappointed because they use this a lot in urology, and it does work.
You're basically saying it's kind of like what we experienced with stool tests and parasites. Stool tests often miss parasites, even though
if it's positive, it's positive. But if it's negative, it doesn't mean it's not positive.
There you go.
Okay. Okay.
You know what I like about it though? It's cheaper. For most places, it's cheaper. We're really sensitive about cost. Maybe to a fault. I don't think to a fault. I think medicine costs too much money. It's crazy. But so this is a lot less expensive and it's faster. And
you're talking DNA.
Yeah, the DNA testing. And what I would say about it though,
DNA versus culturing.
Yeah. And what I'd say about the DNA one, we'll call it that so we don't use names of companies and stuff. It depends on how good of a culture you get. And so if
like a swab
culturing, sorry, thank you. DNA swab. If I'm doing a DNA swab with some of those infection things where I stick it in the sinus where it's full of infection, I get out a goo, that's going to show something. But if you just go into the nose blindly, it's going to be like that stool thing where you may not have sampled enough, because it starts in the front and the whole thing goes backwards. And so are you getting deep enough? Which sinus? If it's this sinus right here, you're going to want to culture right below it, you know, and you know, if it's a sphenoid sinus, you need to go all the way in the back. So, you know, the technique of culturing it is another part of it all.
It's an art form. So so do you culture before a procedure or after the procedure or during the procedure?
These are like awesome questions. We've gone through the whole thing. We've done all the numbers. And right now where we are is two scenarios where we culture. Number one, if we're doing a procedure and there's something that makes your spider senses tingle, I think providers should go with their gut. They should say, listen, I suspect this. And I think it's okay to tell patients, look, the data may refute what I'm saying or it may support it, but my instincts are saying there's something there. So I'm gonna be true to that. So if you think you need to for some reason, then you do it. And the second reason to do it, I'm sorry, the second time to do it is on the back end. So if I see they're infected, I'm not culturing now. Or if you guys ask me to, if you guys like, here's one of my patients, can you please culture? I'm happy to. I never mind to do that, but I'm trying to keep costs down. So why do it in the back end? So many people get completely better. Like, I'm fine. I just saved them another $50.
Right. So that's you know what, my terminology is kind of messing me up, and I think I'm messing up, although that everything you said was great. So culture is what you said about the truck and the labor.
Yes. Yeah.
A swab. To
Yeah.
me, in my CSI mind, like that's also a culture, but it's DNA swab is different.
Yeah.
Okay.
Yeah, it is different. I'm misspeaking too. So I'm just as guilty. I'm so used to call it culturing. So.
Right. So let's say you're doing the procedure, you put the balloon in, it's and then would you culture that, or no, would you DNA swab that?
Only if my spider senses are tingling, because the large majority, what our numbers prove to me, and I've got a great story, but we may not have time for it.
I've got two stories about this actually.
Yeah.
Okay.
No, you go.
take it,
You
Alex.
finish.
Well, I was going to say that it turns out that the outcome turns out to be, it doesn't change our success rate, yet it add an extra expense.
Okay.
So we're always
Yeah,
looking at trying to keep
and
costs down.
my story on this, just real brief, is that from what you told me and what both happened to my husband and myself is we had active infection. I saw the infection when you were doing David's. You suctioned out what you could get, but there's stuff you can't reach, you know. Within about 5.5 weeks, the infection has drained away and is gone because now everything's open and the body can clear it. No antibiotics needed.
Okay, that was my question. Are you matching antibiotics to the mucus excretion, or Dr. Seebecker just answered it, in some cases, you're letting the body take care of itself?
Yeah, usually that's what happens. So it's what you'll experience afterwards, depending how severe your infection is a sinus infection in reverse. Because yes, I open it and I do suffer from being a little bit of a perfectionist. I want to be as clean as it could be. It's like like if I take care of you, it's like I feel like I don't want to like leave stuff there I could have gotten out. So I'm trying to get it out. But I know the scientist in me knows there's still microscopic disease you can't see. It's in that little river of secretions. And that's and we actually empirically will put, unless there's a good reason not to, people on an antibiotic for 2 days before the procedure and 5 days afterwards. So as it's going from this frontal sinus and it's getting swept out, you're rinsing, sure, great. But I don't want to creep into the next sinus down the hallway. And that's why, you know, we're kind of doing what we do to try to minimize the chance of recurrence or the 10% failure rate getting higher because we didn't do our post-op regimen right.
What's your favorite internal consumed antibiotic?
Yeah, I was going to ask that. What works best for sinus infections?
My favorite antibiotic, I've got 5 reasons why. I've got 2 things I do my hand with. This is one of them. It's doxycycline. Number 1, it's not just an antibiotic, it's also an anti-inflammatory. There are only 2 antibiotics out there that are both antibiotics and anti-inflammatories. If either of you guys want to guess the other one, I'm not going to say
it. Well, rifaximin is an extreme anti-inflammatory. I don't know if you know about that one, but rifaximin is extreme anti-inflammatory.
Yeah, see, I'm learning stuff all the time. So maybe there's 3. Azithromycin, which may be the same category, I'm not sure. But they're the 2 that I'm aware of for the sinuses at least. So doxycycline's 1, azithromycin's another, and obviously there's more. You can teach me about that later. Okay, that. Number 2, it's inexpensive. We really like inexpensive, the modern nose clinic, but not, we want value. We're not going to do something inexpensive because it's inexpensive. It works pretty well. Number 3, it's not prescribed that often by ear, nose, and throat doctors, so there's not as much resistance out there in the community. Number 4, there's few side effects. So as long as you don't dry swallow it, just drink some water with it. It's pretty well tolerated. It's pretty uncommon for us to get a patient saying, oh, I had an unacceptable side effect, whereas other antibiotics, it's much more common. And then the number 5, it's one of the few antibiotics that we've got experience using in the pediatric population long-term for the treatment of acne. And so they'll do it for 6 months at a time for acne. And I'm not, again, I'm a little anti-antibiotics, but so if you have to do it for a longer duration, it'd be better to use a medicine that we already have a track record using. And I'm not sure, it could be those people who have acne go on to get SIBO later because they're doing doxycycline for 6 months. I don't know. It could be that there's,
Actually, let me just interject. We've been using doxycycline in the last, say, about 2-3 years, quite a lot more now for SIBO, and having excellent results, particularly for hydrogen. So hydrogen type SIBO. So doxy is kind of like would get both.
And
Cool.
remember, it's everybody's favorite for Lyme in many cases. Antifungal, do you
No,
ever?
wait, hold on. What's the second best now after doxy for antibiotics for sinus infections?
That's a tougher one. There's a whole bunch of good ones. One problem with the antibiotics is sometimes they have advertised to us. We ENTs are wrong about so many things. And one thing is we are so impressionable, and that nice young person shows up and brings donuts and they say, "Can I please talk to you?" And
Well,
you feel
in your
bad for 'em.
experience, what do you find that, what do you like to use?
Other ones to consider are things like Augmentin, because we do
Yeah,
a lot
that's
of
what I was
research
gonna
with that. And Augmentin's amoxicillin plus clavulanic acid. Some people do sulfa, Bactrim. It's twice a day. There's cephalexins are a little bit more expensive. If you've got a Pseudomonas and some stickier, more resistant things like ciprofloxacin or fluoroquinolones could be effective. But now I'm getting to a point where I'm thinking about doing a washout procedure where I just go in there and mechanically wash it out, because they're just really difficult to clear with antibiotics.
Okay, and one last question, Shivan, before we go to the antifungals is, can you explain why it is that we would need oral antibiotics that we swallow for a sinus infection over the lavage antibiotics?
Right. So when you take an oral antibiotic, it goes into your stomach, it's digested, and goes where the bloodstream goes, which is the lining of the sinus. There's multiple places in the sinus where it's well perfused with blood, especially if it's congested. There's just a lot of blood flowing through there, but yet you'll never get the irrigation to get there. So all the research, we've got great research. When you irrigate it, nothing gets in the frontal sinuses. Even when we drill a giant hole out, you have to kind of put your head upside down to do it. And then the maxillary sinus, well, if you cut the whole wall away, I guess, but that's a terrible thing. So if there's a person that has sinus surgery, maybe you could penetrate it. And the sphenoid sinuses, you saw there's a little 5 mm hole in the very back, and you irrigate your nose, how much is really getting in there? Turns out we didn't know. We funded the research ourselves, the Ear, Nose, and Throat Academy did. We looked at nasal steroids like mometasone and other things, and they worked. Yeah, those things, yeah, they worked, whereas the nasal antibiotics didn't. We even looked at nasal nebulizers. There's a ton of stuff we looked at. We wanted it to work because of all the things you're saying. We don't want to mess with the GI tract, but we want to be able to loosen it up. And so
it's basically like it has to just get to the lining of the sinuses, not the open spaces. It has to be along the wall of the sinuses, and that's where okay.
When you just said that you're going to try to just do a wash,
a washout?
A
washout procedure. Washout procedure is a procedure. We kind of named it that. That's we go in with a squirt gun. We squirt, suction, squirt, suction, squirt, suction. And we had to develop a piece of equipment to be able to do that. And a long time ago, I worked with another company. I didn't have any ownership. I was happy they were listening to me. They're helping me solve a problem. And they developed a thing. I don't want to use the name of it. You could still buy it, but it was very expensive and no one bought it. And then we did, and they stopped making it. And so then I went to their competitor. I said, "Would you make it?" Because these guys gave up and they made one. It's relatively inexpensive, but we had to come up with something to do this awake in clinic, because you don't want someone to choke on the water. In the OR, it's simple.
Right. Are you saying that that's a substitute for internal antibiotics?
Well, if we have a person who's failed medical therapy, then we think about a procedure. If they've done one procedure and they're that 10% failure rate, then we're looking at a washout.
Got it. Okay. Thank you. Okay. Does insurance cover this? And of course,
yes, they love it. They absolutely love it. In the beginning, and I knew I was signing up for this job when I signed up for it, so I'm not complaining. But in the beginning, everything new they're careful with, and they're not wrong to be careful, because new things tend to be expensive and they tend to have a higher failure rate. And the people promoting it will often promote it like a salesperson and so on and so forth. But there's so much research now. And so we're getting 90% results, and it's 1/3 the cost. So the insurance companies are even a bigger beneficiary than the patients are. And so if you have an insurance company that doesn't cover it, you might eventually want to switch. At this point, most insurance companies would cover this.
Well, like, let's say I wanted to come visit you and have this procedure. My insurance may be local to my like region of the country, which is not your region of the country. So are you comfortable just giving a ballpark cash pay?
Well, there is that too. We have a cash pay thing, but to let you know, we've got clinics up and down the Pacific Northwest, from Seattle to Portland to here.
But this is a global audience. People are going to be watching this all over the world. So
Right.
Are you able to give a range of cash pay?
Yeah, well, actually, and we actually, I think they've got it pretty much tightened up. We see a lot of people who fly here get it done. We had 3 people just a couple weeks ago who came in. I told them all, I said, "You're gonna stay at my house." They said, "We are." I said, "Yeah, you stay at my house, and I'm gonna do this. I want to videotape you afterwards, and then I want to put that out so people can see what it's like the evening afterwards, the morning afterwards, the day afterwards." And I interviewed all of them. And I told them afterwards. I just showed them over the weekend the video. I said, "If you're embarrassed, we won't use it, but if you're not embarrassed, we'll use it." And so we get people coming from a distance, but what the problem we have is that and I think sometimes people don't understand, it is a favor for us to do it to people at a distance because it's hard for us. It's easier to have the person right down the street that we can see over and over again. And we're not doing this to make money. We're not doing this to like, oh my gosh, whatever. So what we do to solve that problem, people from Canada, a person from Germany came the other day. They fly in and they say, okay, I'm going to commit to this price, and they pay this prices for this package. And that package means they're going to get CT scan, and we'll use that CT scan to decide which sinuses are appropriate. And if it turns out it's very, very few sinuses, we knock the price down to the lower one. But if it turns out it's a whole bunch of sinuses, or some of them tell me, I want you to do all the sinuses anyway, because it's not easy for me to come back. So they're both tight and one's infected. Can you please do both? And so that makes sense because it's very low risk. So we have it like that, and it works pretty well because we don't want to overcharge people, but we also don't want, it's like we can't, oh, you got to get the CT scan. Oh, I didn't get it.
Yeah, no.
Yeah.
So how many visits are there? And would it depend on how many sinuses there are?
Well, actually, if you said that very fewest number of visits, we'll do virtual appointment initially, so we can make sure that, are we missing any medical therapy that could work? And so a lot of people just get better and they're fine. And if a person has a CT scan locally, we'd love to see that, but we need to like see it, But sometimes that's technically hard. Sometimes the patient's like, screw that, it was a waste of time. I want to do it on site. And our CT on site, that appointment is one of my favorite appointments. I think it's a really great appointment. But anyhow,
actually, I just want to interject for 1 second here about CT. I'm sorry to derail. I just want to say that your willingness to do CT and your discussion of CT as the gold standard for diagnosis here is incredibly important, because I think this is one of the biggest problems we're facing for most people trying to solve this problem is docs are unwilling to do CTs. And I'm speaking from personal experience. I spent years trying to get David just through the, like his, he had like a medical home, like a primary care. That was the way our insurance worked. And they would choose who they were sending him to. We couldn't choose. And everyone we went to, because I knew there was something structurally wrong in his nose, everyone we went to wouldn't do a CT. You were the first doctor that we found not only willing to do a CT, but who like relies on it and discusses it in the way you do. So I just want to point out to people, for anyone who's looking for a provider in their local area, make this be one of the key things. Will the doc do a CT? And are they into doing CTs? This is the gold standard diagnosis.
Like SIBO and you don't have a breath test. Come on, people, right?
There you go. Now, I derailed the conversation. Please bring it back.
So, okay, so let's say I feel like I might have silent sinusitis, the word. Okay, I'm going to do a virtual appointment with you first. We're going to have a little chat, and then I may or may not come in for a CT scan. What if I have a cone beam from a biological dentist? Does that?
Yeah, I mean, the cone beam is the same technology we use. And so it's this, and when it comes to CT scans, what I would say in general is like, we'll take any information we get. So don't like, I don't want to waste it. It's like, oh, you got it. Let's see. So that's wonderful. We welcome it. But then there too, we're doing 450 slices or 600 slices. We like in our local area, we're redoing CT scans often because they're never the high enough quality to catch stuff. And I couldn't care less of it from like, it's not some money-making thing. It's because we need to have the root cause, figured out.
We know you don't need to defend that. We're with you 1000%. We're with you. Okay, so then you're like, oh yeah, it looks like you have an issue.
Mhm.
Then a potential soft balloon process, which name I just escaped me.
Sinusoft. Yeah.
Sinusoft. Then
Yeah.
potentially a sinusoft.
Yeah.
And how many post sinusoft visits would typically need to
Well,
happen?
when you're coming from a distance, I mean, we'll do a virtual follow-up and see how things are going. But if you're somewhere we can take a look at you, we're happy to take a look at you in your nose with a scope to make sure it's healing well. We'll often do it like 1 or 2 weeks afterwards, and we'll do it again, a month later to make sure there's long-term results for that. And also too, your journey through the whole thing. One of my favorite parts is it's the onboarding process. It's a software driven where you tell your history. And patients are like, because it has conditional logic, it's really cool. And so if you have X, Y, or Z symptoms, it tees up different questions based on that. And there's lots of videos with it. And so what happens is when people have their first consults with us, when they've done that, the provider has memorized it. They've gone through it all. And then we actually even profile you psychologically. Like I had a patient this morning, she came from 2 hours away and she was an intellectual patient. And so we did like 2 appointments in one because she was able to retain it. She came from a distance and we asked her, according to our software, this is what you would prefer. You want more answers. The more answers, it doesn't overwhelm you. It reassures you. She said, absolutely. And then when we were done, we said, was this what you want? She says, it's perfect. It was like, but that would have overwhelmed another person. So another person, you take one bite of the apple and you put it down.
That's nice. And then could you explain what tonsil stones are? Because I don't think everyone knows what they are.
So the first thing doctors do when they get things like that is they name it something Latin so it sounds really fancy. And so we call it tonsil lifts, which is tonsil stones. So it's not a definition, it's defined with it. So what really is it? And what I would say is that the crypts of the tonsils, we're taking tonsils out all the time. We probably do it too often. And the younger version of me was probably very guilty. I didn't know. I thought you should take them out. And so I took a lot of tonsils out, but they're probably there for a reason. I can make a few arguments to try to avoid getting them out if you could do that. So generally, as I've gotten wiser, see my gray hairs, I'm a little bit less is more. And it's like, it's there for a reason. You have to have a good reason to be being surgical things, So within those crypts, and there's definitely an immune system, lymphatic kind of, you guys don't know about IgA and everything else. You guys are experts with this stuff, but so there's stuff going on there. So does bacteria get caught in there and they're getting caught in the crypts and therefore it just kind of reproduces? Yes, it's probably something bacterial. Why? Because again, I'm old enough. When I was younger, we thought we were so smart. When I was doing my training, we give a person with tonsil stones antibiotics for like a month for 2 months. Because back then we weren't as aware of the dangers of antibiotics. And the person would come back and it's like, how are your tonsils? Well, they're all gone. It's like, I'm so smart. All right, you're welcome. I saved you from a tonsillectomy. But guess what? They always came back again. They often came back again. And so then we got to the point where we're just going to take your tonsils out. There you go. And so I think the next level up is what we're talking about today. Go further upstream. You'll always fix the highest upstream problem. If there's infection here and it's draining all the way down back across your tonsils, you don't want to keep treating them and poking things out and shooting with water picks. You can just fix the infection up here and then see if it goes back to normal.
Are tonsil stones made up of like calcium?
Yeah, they can be kind of hard. And we say calcium, they're firm. They actually kind of vary a little bit, but they're like little tiny stones. And I'd have to say, I can't tell you off the top of my head the exact composition.
No worries, no worries.
Yeah.
I was just curious. Okay, so then speaking of the lymphatic system and the glymphatic system, which is the lymphatic system of the brain, do you see a relationship? So you kind of answered it. You see a relationship with the sinuses and the lymph system. Do you have any just general observations about that for people who are like, I have a lot of pressure in my head? It could be the sinuses, but also like, do you see how when the sinuses are fixed, that the lymphatic system would be vastly improved, right? That's just what my logic is.
It's so interesting because, this is what happens. I think that you guys are seeing patients similar to us that they're losing hope. They don't know what to do. And the traditional medical system, I'm not here to make fun of anyone. My wife's Korean. I love her to death. And she's like, in Korea, like Eastern and Western medicine is one thing, which is as it should be, right? It's the same darn thing. But the traditional medicine is like, I don't know what it is, so you're crazy. Right. I mean, they don't say it, but you have an 8-minute appointment and you get that, you feel like you're getting stiff-armed a little bit. So when you find problems that are really holding a person back, they're stuck and they just can't live their life, like they've got this pressure all the time, and you do something in 30 or 40 minutes that relieves them of that, it's flipping awesome. It's like it's the coolest job to have, where you can get such happy people. So, I would say that if you run into a wall, you don't know what else to do, you have nothing else, why not get a CT scan wherever you happen to live in the world? Get a
Right.
CT scan, and when you get the CT scan, get your smartphone and say, I want to shoot a little video clip as they move through it slowly back and forth. That's all I need. That's all I need. And then if you stuck that thing there, I could review that. And so if I see, oh gosh, you do have infection, then I can move virtually, even if you're in Germany, I can move on with it and say, okay, I know it's your maxillary sinus and so on and so forth. Let's give you all your treatment options and so on and so forth. When they come to show up here, they're flying so far away, we're probably going to repeat the CT scan just to make sure we're not missing anything. But in general, we have a pretty good idea what we're up against. So I think we can handle people at a distance pretty well, as long as they understand that we want to get it right.
Well, of course, everybody wants us to get it right, right? We want to get it
Yeah.
right too. How long do I need to stay in town before I can get on an airplane?
Well, literally, and some of those interviews, those people, I was just back and I was just seeing one of them the other day, and she was like, I did the procedure on a Thursday, and then the very next day I'm rinsing my nose. It was nice to be in town the next day because in case something happened, I was even though you said it'd be fine, I was apprehensive, and it was fine, just like you said. The very next day I could have flown out. And we have people usually come in on Thursday or Friday, and you'll fly out on a Sunday or a Monday. So you really don't have to stay long. The biggest risk of this is bleeding, a nosebleed. And again, we're tracking numbers. And every time we get a nosebleed, we do a debriefing and we bring the whole team together and say, what could we have done differently so that didn't happen? We get right now about a nosebleed 1 out of every 423 patients. And I've got a cautery device in all of my clinics. I've never used it. I don't even know how to use it. I was joking with one of the nurses the other day. I said, I should probably use this at some point, because what happens if I actually need to use it? I don't know how to turn it on. And they're like, yeah, you should do an in-service or something.
Yes, but you really have excellent post instructions how to handle nosebleeds. So you're well equipped at home, as well.
What I didn't ask you before, like, do you ever find, if they do the culture, this is the culture, and they find that fungal ball is fungus, then do you prescribe antifungals?
The whole fungus thing is a whole time. We could probably do a whole thing on fungus balls.
Well,
because I think it's something that we'll do a short one, a little short thing with that. When it comes to ear, nose, and throat, there are fungus balls where you can see it, and on CT scans, like if we did a fungus one, I'll probably try to get some CT scans to show you and tell you the story as they presented, and there you go. But I'd say sometimes I can tell from looking at the CT that I'm suspicious of a fungus ball. Sometimes I got to tell you, I think it could be a cancer. I don't know if it's a cancer. When it's a fungus ball, I'm happy. But sometimes, like last week, I had another fungus ball. I get a fungus ball once or twice every week or so. So they're not rare. But when you have a fungus ball, the antifungals won't clear it. You have to physically get it out. Is it because we don't have good enough antifungals? Maybe they'll come up with some new antifungal. I'm all for it. From an ear, nose, and throat standpoint, I like the challenging ones because I think it makes you better. But these are things that are a little bane of our existence. It's like, I'd love to give them a medicine and not have to whatever, but you're trying to clear it out mechanically. And with our equipment that we have, our technology we have in terms of the washout, I can get into a sinus, squirt suction, squirt suction, squirt suction, and I can go into it and clear it all out. So it doesn't matter to us. We fix fungus balls in the clinic like we do all the others.
Okay, $1 million question right here. Mold. So I worked in a moldy building for 20 freaking years.
Yep.
And I was a mold denier because I was like, what am I going to do? Leave? So finally one thing led to another. That's a whole other story. But when I was there and was so ill, I went to an ear, nose, and throat doctor.
Yeah.
He's like, well, you have a nodule on your thyroid and you have allergies.
Don't worry about that.
Yeah, I'm not worried about it. So, and you have allergies. And I'm like, in my head, I'm like, I even said to him, I really don't have allergies. He goes, well, it's all inflamed and red in there. And I'm like, my husband has seasonal allergies. I know what that looks like. That's not me. So I'm like, that's weird that he would say that. Well, this is before I realized I had mold. So I went to him again and I was like, hey, I'm in a moldy building. He's like, no, just like, no. And I was like, And then I went to a functional doctor. We did a nose swab and is it possible that I had MRSA in my nose? Because that's what
Yes.
the test said. Yeah, the test said that.
Mhm.
And that was about 10 years ago, 15 years ago. And I'm doing so much better and all of that. But I just wanted to know, like, how do you see like mold colonized in there, or is that like a fungal?
That story is powerful. That was like a good case study. And well, that doctor could have been nice or not nice, but it was basically the stiff arm. And I think that as a patient, I'm a patient too, guys. I'm not like just a doctor. I would be okay if my provider said, I'm not sure what's going on.
I
But
would
it
rather
definitely
that.
could be, yeah, it could be just exactly what you're saying. And what I can do is I'll keep your name on my short list of people that I'll keep my eyes peeled as I go to meetings and so on and so forth. Or hey, there's this clinic right down the street, the Modern Nose Clinic, and that's all they do is the nose. So if someone's going to know something about the nose, maybe give them a shot. I would think more highly of them than bad of them. And I feel like almost like that doctor is looking, oh, we can do allergy stuff. I can make money on that. I can do that. Oh, I can do a thyroid surgery. So these are things they could do that could commoditize instead of solving the problem. I don't know. It could be a lovely guy. You may have thought you didn't have it.
I don't know. He was like, oh, you're into that SIBO thing. My wife's into that too. Yeah, she's crazy. I'm like, I'm in the wrong place.
Oh
Yeah.
God. Well, let's just think about this though. The information you gave us about the fungus ball is fascinating, that there are these balls of fungus that need mechanical removal, because in the toxic mold illness world, we know that what is absolutely part of all treatment is using antifungals in the nose, because they always say there's fungal colonization in the nose and they must clear it, right? And so this is something super important for people to think about who are having trouble clearing mold, and in their mold treatment is they may have a fungus ball that needs to be mechanically removed, because even lavage or oral antifungals can't do it. So that's a key thing you just told us about from your ENT perspective.
Oh my gosh, it's like you said, sometimes when you're stuck and you don't know, slow down, do more knowing and less guessing, do a root cause analysis. We're not doing studies
Get a
unnecessarily.
CT.
Yeah, CT could be useful because it's 450 pictures. We review it for 20 minutes. And when you're done, hey, look, if it's clear, you'll feel like, no, I know it's clear. He read that so thoroughly. And there are some people, Allison, that I might look at it with them. And if they said, like Shivan said, hey, do you think that I could have a fungal disease? And I'll look at it, and sometimes it's perfectly crisp. And I'm like, I guess it's possible, but you look really, really healthy on this one. Is this a high symptom day, a low symptom day? If like it's a high symptom day, it should show up. Like, I don't know. The guess would be away from it. But a lot of people, there is some swelling of the lining of their nose. You start to look at the patterns and stuff. So I think especially when you live in moldy houses in Oregon, mold is ubiquitous. And so, and really, I went deep down on this one here. I'm really interested in mold. I think we just don't completely have our arms around it completely in the ear, nose, and throat world. But the gross mold ball, the visual stuff you can see, where you see a chunk of stuff, you get that out. These people are so grateful. Like, oh my gosh, I feel so much better. But it usually shocks them too, because afterwards, like, I feel better. I lived with this for 4 or 5 years. I didn't know because it came on so slowly. They'll come back and see me in a year. Can you double check just to make sure there's nothing there? It's worth it for me. I'm like, well,
I did that. I had to do a double check. My CT was
Yeah.
clear like 4 months later, just to be
Yeah.
sure.
I had a tonsil stone, and I had a little cough, and then I went to the ENT because of a different ENT of a sleep issue, and she's like, "Oh, look, you got a tonsil stone. It comes out. I haven't had a cough since." So like that's
awesome.
a whole other thing to think about, because now my sisters have these little coughs, and I'm like,
I think that makes the point that you go upstream. So you went upstream instead of focusing on the cough, which is fine, but you said, well, could there be something further up? So that tonsil stone, cleared some, maybe there's fungus with the tonsils, maybe these are little fungus balls. I don't know.
Yeah.
But, I haven't done like, if you said you want me to talk on it, I'll go back to the literature and read and see. So I could tell you more clearly, but I would say that was probably an upstream problem. Maybe you have a sinus problem here that is infecting your tonsils, but if you're doing well, then that's great.
Well, it's all relative too, isn't it? Okay, so hold on. I have this other question. So they would have to call your office for costs. We didn't really cover that. And so I'm just going to do, I don't know what day anybody's watching this, what year you're watching this. And I don't want him to say the price, because he may have to increase his prices because of who knows why. So let's have you call the office and find that out. And the phone number is 503-584-1174. Look online for a modern nose clinic in Salem, Oregon. Okay. So the other thing,
Or Tualatin, Oregon.
or Tualatin.
Or
Okay.
Bellevue, Washington.
Thank you. Okay, hold on. I'm almost done here. Okay, the mold, right? Tonsil stones. Got that. Got that. Got that. Got that. Okay. Hold on, because dental. Okay, dental. So I'm really into biological dentistry, and I've done a whole summit on it. And I had cavitations. I've spent a fortune on biological dentists who were not really biological, like traditional for most of my life, semi-biological, holistic. Then I went to a real biological dentist, and it was very clear that this other person was not really a biological dentistry. But it is what it is. So do you see a relationship between the sinuses and oral health?
My last patient just this morning, if she was here, she would come on over. She came from 2 hours away. She went, my wife is not only is she from Korea, where they have like thousands of years of, she's like Eastern Western. It's like one thing, it is one thing, but she's also a professor at the dental school. So she's a dentist. And she also treats snoring with an oral appliance. We call it the Dream Bite system. So you don't have to do CPAP. I mean, you can do CPAP, but if you want an alternative, it's nice to have choice.
And what's the name of it again?
Well, she calls it the Dream Bite system. It's a collection of 14 different oral appliances, so she can match the right oral appliance with the right patient. And like what most, if you want to know the difference between a holistic, dentist or and a person pretending, if you want to know the difference between a sleep specialist and a person who's not, if they only offer you one oral appliance, well, they don't really specialize in it. She offers 14. So, but anyhow, so I get to talk to her all the time about dental things, but we really go home, we're like husband and wife. We're not some crazy people, but I'm just saying. And so I would say when it comes to the teeth, most of the dental world would say is if there's sinus disease and dental disease, to treat as a priority, to treat the sinus disease first, hoping that it's covered by insurance too, and it could be less expensive to the patient, hoping you can preserve your teeth as much as you can, because sometimes if you start the teeth first, you might get a tooth pulled or get a root canal or whatever else, more destructive processes. The sinus stuff, you do it and it takes 30 or 40 minutes and it's fixed. And so it's a much simpler, it's more of a procedure than a surgery. But I would say that when it comes to biologics, that lady had her biologic dentistry. She had her procedure done a little while ago, and then she came, to see me 2 years later. And she happened to have massive sinusitis, and she was a little bit shocked, but she had it. I mean, I almost want to take the computer over there and show it to you, but I didn't get her permission, so I can't do that.
Fine. I do one last thing, and then we're going to wrap up. First of all, Dr. Seebecker, thank you for making this happen by connecting us with Dr. Skarada. Let's just talk about sleep apnea for a second. And you've touched on it. You've said your husband, Allison, doesn't need a CPAP anymore.
And he had severe sleep apnea. They actually stopped the sleep study, said it wasn't like ethical to continue because he was so severe. They just like, we're stopping, go home. We're getting you the CPAP, no longer needed.
That's amazing. So this is a huge message of hope, because for sleep apnea can kill you. It has so many health ramifications. You have a stealth infection with the sinuses, so many ramifications, potentially connected to dental, stealth infections, so many ramifications. And so if you have sleep apnea and you can get more of the airway opened, it just makes a lot of sense. All of the other stuff aside, it's worth it for that alone in many cases. So it's something for you to seriously consider. Petunia wants to get in on this. So thank you, Dr. Skarada, for all of your work, because amazing. You're saving lives, you're saving lifestyles, you're helping longevity. You are potentially, in my opinion, like helping save brains as well, because all those infections hitting up into that cranium and the brain possibilities, there's like, it's another mystery.
And everybody whatever jobs they do, now they can do them better. And, for me, I would have to like be on the couch half the day. When we say fatigue, it just sounds like, oh, nothing, you're a little tired and need some coffee. No, This can be serious, and you're accustomed to it, so you hardly even realize it. So think of all the productivity and all the life and happiness you're giving back to people. It's amazing.
It's so if anyone becomes a new patient, you'll do that new patient paperwork, the onboarding process, and it sorts you out. Wow, you might have a sleep problem too. We treat sleep really well at a distance also, because we can mail out the home sleep test to your house, and we can do virtual with that also. So that lends itself really well. But the airway begins with the nose. So, and sometimes if you just open it, and you can even kind of wonder, if your spouse has sleep apnea and you watch them, if they snore more on their back, it's positional sleep apnea. And positional sleep apnea is the weight of the tongue collapsing back and blocking off the airway. And they're the ones who do great with an oral appliance.
Okay. But no matter what, it's good to open the sinuses.
Yeah.
And the airways of the nose. Okay. With that, thank you. Thank you. I know this was thought-provoking and a lot to digest, so you might want to play it again and again. You might want to get that transcript going so that you can take into consideration all of the information. Inch by inch, it's a cinch. Don't get overwhelmed. Instead, this is a message of hope and possibility and potential answers, and just really cutting edge. And it's very exciting. And we're in deep gratitude for your work. Thank you. All right. Take care, everybody.
Take care.
Thank you so much.
Bye.